Hi, this is Fernando Gomez Sancha again, and this is a case of a relatively small gland which has some interesting pointers, I think, and it will allow me to reflect a little bit on some important aspects, especially when you don't have a very good plane, as in this case, and as you will see in this case. So this is the beginning of the procedure. Of course, we have a look at the bladder, check the UOs if we can. I never force this step too much because it could produce some bleeding, and here we have to identify where the sphincter is. One trick is to take this measure from the varus upwards, which seems to be quite correct most of the times in smaller glands, but as you will see, I will make a mark there. But then when you come out, you see the real edge of the sphincter. And there's usually a bit, you see, between the edge of the sphincter and the mark I did. So we're going to take that as a, the reference of the anterior margin. These smaller prostates give you relatively low mobility with your scope. And I never use any force. I just need to reach very carefully, so never force your way in. I think progressive mobilization is the key, to what we want to achieve. So having marked the white line, this is the entry into the plane, usually from the floor of the varus coming sideways. Sometimes we enter in a very nice place, sometimes it's not so nice, and I insist, you shouldn't get stressed by not finding a beautiful plane. Just try to find a plane that looks capsular. And, that's usually a relatively smooth plane, relatively white in color, not so yellow. And also a plane that is not excessively deep, so sometimes we have to find a plane that looks capsular and there is no beautiful plane. So here I'm joining both entries, both lateral entries in the midline by cutting the frenulum on top of the verumontanum. And here what I'm trying to do is to develop a posterior line. You see that there's no good plane. There's some hint, that probably that is separating somewhat nicely for a bad plane, but it's not easy sometimes. Well, that's the 12 o'clock mark we did here, over here. This was probably a case that I was performing during a visit from someone, so I was explaining things in the operating room. And again, this is trying to take the line. You can see that there is some indication that plane could be okay. Often when you follow a capsular plane, you're a little bit below the anatomical plane in this region, which means that we are a little bit extra anatomical, coming a little bit deeper into the peripheral zone than that. But that's okay. At least we are inside. We're not perforating, and we are developing this nice plane. Okay, so this is the steps I follow to do the apical liberation. Initially, I deepen the white line first, a little bit, and then I try to initiate the lateral aspect. You see, here we will have to do access incisions. When we do these incisions following the white line, you see, what happens, the tissue opens like a book, a little bit, like 2 pages of a book, and we need to go up to the page up there, to find the proper plane. I don't know if that will help you understand, but initially these incisions open up the axis. They help protecting the sphincter, and it's important to mobilize a little bit towards the bladder neck, because as you can see now, we are transitioning from the lateral line to the anterior line. And the moment the scope can, be on top of the apex, and you start developing a little bit of the anterior line like that, you will see how the 12 o'clock area becomes much more visible and much more recognizable and affordable. So here again, deepening the white line first, then look for the lateral, don't go up too much, just a little bit, and then mobilize the apex by going toward the bladder neck. That's a little bit of hemostasis, and try to connect the line. This is the posterior line, that's the lateral line, there's a good connection. These lines are going to be our orientation system. So here again, you come up, we try to keep on the white region because that tells us that the sphincter is going to be okay. These are initially access incisions, and you see that we go way up to look for the proper plane. So we opened, the pages of a book, and we go up, to the upper page of this book to look for the plane. And then again, mobilize, mobilize, mobilize. We need to mobilize the apex. So don't stay apical, just go a little bit inside, maybe, 2 centimeters, depending on the case. Here again, this is another access incision. Again, this now is almost horizontal because we are below the sphincter. You see how these incisions change direction? But then again, we go up all the way to look for the proper plane. And this is how we progressively release the apex, progressively detach the anterior apex from the anterior capsule, peripheral zone. And when the endoscope is able to descend the apex a little bit like this, we gain a lot of mobility. And as you will see, we have a starting point here anteriorly. We see the 12 o'clock fibers very clearly now because the apex has descended, you see? So now initially we cut also to access, so it would be a horizontal incision, but right away after some millimeters we have to look up and make sure that we remove all the apical anterior BPH tissue. We don't want to leave tissue there. Some people say they go inside, they try to leave tissue there, but I think if you do this apical liberation, if you score the mucosa properly when you do your white line at the beginning, there's no need to leave tissue anteriorly. This tissue can become obstructive over time. And as you can see, we have a circumferential line of dissection around the prostate. We have perfect visibility, and now we can go around the adenoma. You see, the plane is not beautiful, but we trust our lines. You see, the lines will tell us what direction, we have to work, and we always need to look at the quality of the tissue to see, we don't want to go too deep. So when I do this dissection of the lines, I try to use the energy very softly so that with each pass I get a little bit of dissection, but not too deep, so there's no chance to perforate, to make a big hole. So you want to progress carefully, okay? This is, just taking the lines towards the bladder neck, trying to get a relatively smooth effect if you can. Of course, sometimes we bend the rules a little bit. These are basic principles that you have to understand, and then you have to decide interpretively how you're going to use this energy. So again, this is the anterior line. You see now the scope is pushing the adenoma downwards a little bit, because we not only have the 2D, comprehension of how the line goes, but also the 3D. So we know the anterior part is going to go down if we want to approach the bladder neck. So we have to, progressively dissect this line. Sometimes, you might have trouble, or you might find it difficult to often we see this sign where you see the circular fibers of the bladder neck, and below you see the vertical fibers of the bladder neck, and you know that you're going to enter the bladder. But sometimes it's not so easy, and you're afraid that you could perforate anterior to the bladder, you know, that you could go in too high, you know, and you see that's incidentally a nodule. You can see that. So we always want to take these nodules out. And well, you see, we're coming downwards, looking for the bladder neck area. It's not so clear. So what you can do in these cases is you can go inside, again, inside the prostatic urethra, and make a small cut at the bladder neck there, and it will help you localize the entry into the bladder. Okay, so basically, sometimes when you come back here, you already see a little hole, but if you don't see it, it means that you have to keep digging downwards, and there it is, you see? So if you lack the confidence to enter anteriorly at the beginning of your learning curve, this is a good trick. So the interesting aspect, I think, of this technique is that it is useful for any energy source you use, because this construction of the posterior line, the lateral lines, the anterior line, making sure that you connect all the lines, provides you with a roadmap to understand anatomy and to carefully progress towards the bladder neck. There's some instances when you want to perforate the capsule, and this is, for example, one of these moments. You see, we want to perforate that because we know that on the other side we have the bladder. So in these cases, often I do a little bit of contact with the tissue. I try to avoid contact because contact is dangerous. You know, when you do contact, you can do a little hole in the capsule, or you can penetrate, except when you know where you are. And look at the beauty of this circumferential line. Here we have to interpret. Sometimes the plane is not very good, and we always have the possibility of correcting. You know, if you leave BPH tissue and you realize later, you can go back and take it out. You see, but often having these lines gives you very good orientation and understanding, you know, and many times the capsule, the anatomy is not helping you, you know, or maybe the plane you're following is not very forgiving, or it's inflammatory, you see. So carefully progress, always do wide movements. You see, I don't do little ponds. I try to always carry a nice ample line, you know, wide lines that go here, you know, usually from one side to the other, but here it goes up and down, and try to keep these lines broad and do wide movements. You don't need to rush anything, just try to keep working. You know, speed in the operation doesn't come from moving very fast. It comes from trying to be effective. You know, work slowly, but try to work constantly. Keep the posing time short. And here, you see, is where we are going to use this principle, I would say, where when the plane is difficult, when the fiber is perpendicular to the capsule, like it is here, you see, you don't want to fire against the line of dissection. You want to fire on the side of the adenoma, which means that when you are below here, you need to point your laser towards the upper part of the line. You see here, very carefully, I'm trying to avoid to put energy on the capsule. So I keep the energy on the side of the adenoma. My fiber is very close to the adenoma. As we go more lateral, you see that I also try to stay closer to the adenoma, because I want the energy to disrupt and to cut the fibers that are joining adenoma and capsule, but I don't want the energy to penetrate in the capsule. Okay, so here you see also I get very close to the side of the adenoma to dissect these relatively difficult planes. You see that the energy is quite smooth, so we get some dissection effect that is quite smooth, quite careful. And I don't necessarily have to advance too much with one pass. I would rather do several passes, gaining a little bit of dissection with each pass. Because if we see that we are deepening too much, or if we see that the capsule is thinning, we can always correct more, right? Get even more close to the side of the adenoma to try to avoid making a small perforation bigger. And this is it. It's pretty simple. Of course, you have to understand it, and then of course you have to be able to do it properly. But you need a steady hand. You need to move very slowly, and you need to control the fiber, the distance. You see here, when I see the capsule a little bit thinning, I try to get closer to the adenoma. In this case, and always, I think it is a good practice, I think, to try to get the side detached completely, so you can see the bladder neck. So instead of continuing dorsally, posteriorly, I'm going to go to the lateral aspect here, you see, because I was seeing that the capsule below the middle lobe area was getting very thin. So it is much safer to do the sides first. There was some nuisance bleeding, little vessels that can bleed a little bit. And probably I will try to do the same on the other side. The other side is a little bit more developed. You could see the bladder neck here. You can see how the fiber is keeping up, close to the adenoma. And you can see how this way we get away from, deepening more into the capsule there. And as I said, later on you will check the plane. You see how my fiber is way up, far away from the line of dissection, because we don't want to deepen into the capsule, and that looks very, very capsular. With the gain in mobility, sometimes we can flip one lobe. You see, I initially lifted the lobe a little bit, and that gives us much more space, you see, here inside the fossa. Now this is the other side. Remember to keep up, far away from the capsule, so that the energy can cut these little fibers without penetrating into the capsule. This is how you negotiate the difficult planes. Carefully remember wide lines. Keep a line that you can recognize, that will serve you as a, and that's how we negotiated, initially, or avoiding to perforate when the capsule is getting thinner. Of course, you want to remove, you want to be aggressive, but always have in mind, that you don't want to perforate too much. And you see, this is now 18 minutes inside the procedure, 19 minutes. That's the checking the UOs. So you need to be systematic, try to work and focus on advancing the operation. Little battles that you have to win to make sure that you win the war at the end. So small steps. And again, I will continue to post cases, because I think the more you see and the more you understand, the easier it is to perform this procedure successfully. So again, you notice that I turn the fiber at 6 o'clock for this part, because I think it's a little bit more comfortable. And now, of course, we have to check hemostasis. That's bladder neck fibers. And it's important, if you use a holmium laser, to check the fibers, to check the the bleeders at the edge, the mucosal bleeders. Sometimes with this virtual basket setting, I think it's very nice hemostasis. First pass hemostasis is quite good, but the explosive nature of these pulses, I think, sometimes disrupts the mucosa and you can have bleeding. Bleeding that you won't see until you start morcellating. So you need to get inside, the bladder, look at the edge of the mucosa and find these little vessels. So when you look at the capsule, it looks very capsular. We haven't left much adenomatous tissue, maybe in some areas like there. We went almost out, we deepened a little bit on the anterior fibromuscular stroma. But if you can correct and you don't perforate, you win. This is the idea, to recognize the deepening and to try to, and these are the bleeders I was mentioning before. These are mucosal bleeders. Unless you tilt your scope a little bit and try to look inside near the edge, you won't see these vessels, and these can definitely ruin your visibility during morcellation. These vessels are looking inside the bladder, and when you look from the fossa, you don't see them. You have to get in. So this was it. 21 minutes of operation. We didn't rush it at all. It was just, I think, knowing what to do, knowing the steps of the operation, knowing how to increase the mobility of the apex progressively so you can reach the places, especially the 12 o'clock fibers, without making big pushes against the sphincter. And you will see that the look of the sphincter at the end of the procedure is quite satisfactory. So not a very large gland, but sometimes the smaller glands are a little bit more challenging because the quality of the plane is not so good. So I wouldn't recommend you to start with the smaller glands. If you're going to start, try to go over 50 grams, 50 to 60, 70. Not much larger, because at the beginning you will hesitate a lot and this will consume time. So that's the morcellation. This is the Perenya system, and it is quite reliable. It's a little bit tricky to set up at the beginning and to get used to it, but then once you know how it works, it's a very solid morcellator. You can see that most of the times you are static in a safety point. I try to position the tip 1 or 2 centimeters above the bladder neck, and I try to keep the blade a little bit inside so I can see some of the bladder and make sure that I'm not getting anywhere close to it. That's the beautiful sphincter preservation. Thank you very much for your attention again, and all the best.